Thank you, President Professor Sally Chan, Tonghua College Senior Management, distinguished guests, ladies and gentlemen. Thanks for inviting me to the opening ceremony for the TRC-DMH. It's my honor to come back and return to Hong Kong, a place where I was born and received my medical education, and share with you my journey to translate my technology, which is the infrared brain scan, from maybe a research to clinical application on our patients. So today, the topic of my talk is clinical application and translation of functional near-infrared spectroscopy. I will use fNIRS throughout this presentation as a short term in establishing psychiatric diagnosis, and this is a Singapore experience. Now, besides working in the Department of Psychiatry, I also work in the iHealth Tech, which is in the middle here. And this institute was established around 10 years ago. This is a place where doctors, medical doctors, engineers, and some commercial company work together to apply a technology to improve patient life. The direction. This is the next slide. So, okay, so let me try. Okay, now it works. Okay, now I know today we have people from different backgrounds. Our focus is on psychiatric disorders. So although some of you are very experienced with psychiatric disorder, maybe some people are new to this field. Let me introduce what are the common disorders we have. First is depression, number one, and then the second one is panic disorder, and then we have schizophrenia, and post-traumatic stress disorder, bipolar disorder, dementia, and phobias or anxiety disorder. Some of the disorder I could do research in Singapore or Vietnam. Some of the research I'm still looking the opportunity like dementia, because it's not easy to recruit people with dementia in Singapore because this field is very competitive. This question actually mainly asked by patients: is mental health or a psychiatric diagnosis, is it very subjective? People have different views. Now the demand comes from the patient. They will ask, doctor, do you have some objective tool to show that I have depressive disorder or I have schizophrenia? Because it's mainly based on a clinical interview. It depends on what I say and your interpretations. Yes, from this sense, people will find that the procedural assessment in psychiatry is a bit subjective. Now, the other thing is, so far we seldom convert this into number. I think the closest is to count the number of the diagnostic criteria based on this menu called the Diagnostic Statistical Menu, DSM. So people fulfill 6 out of 9, then they have this condition. But that is the one that have number. Otherwise, there's not much number involved. Now, you know DSM-5, every 15 years, they will change to a new version. So now it's in this era, it's DSM-5. I think maybe 10 years later, called DSM-6. So they're changing the diagnostic criteria, but the principle is the same. Interview the patient, counting the number of symptoms, but it depends on what the patient tells us or how we interpret it. So again, patient asks, do you have something like ECG? If I actually have a chest pain, I come to the emergency department, the doctor talk to us, examine us, and do a ECG, look at the waveform. Do you have something like this in psychiatry? Of course, maybe some people go to different center, people still try to look for a cost-effective way, but many of the centers still, okay, I talk to you after 20 minutes of assessment. I think you have this diagnosis, and I will prescribe this medication or refer this person for psychological treatment. Now, this is a hot topic, precision medicine. Then, of course, today we focus on mental health or precision psychiatry. What will be the ingredients for future precision psychiatry practice? I highlight some of those, and maybe we are still in the process of achieving that. Number 2, long DSM symptom and pathology. Okay, DSM it depends where you receive training. Our trainees in the United States or Canada, they actually remember the DSM by heart. But for us, we use this as a reference. So we also ask, how about non-DSM pathology? Is there any biological pathology we can include in future diagnostic criteria? Number 4, measure the symptom more objectively. I know this is very new to our colleagues. So besides talking to patient, is there a number? Just like a doctor suspect a patient have anemia, the patient look very pale, but they will look at the hemoglobin level. If above this level is normal, below this level, patient may need blood transfusion. So do you have something like that more objectively? Now, psychiatry is very challenging. Let's talk about inattention. It's overlap. Of course, a very famous condition called ADHD, they have inattention, but depression, people with major depressive disorder also have inattention. People with dementia also have inattention. So it's overlap. And use multimodalities. So we will never say with a technology, there is no more doctor interview. That is not the case. Look at our medical colleagues. Someone suspect, okay, the person have a goiter, which is something to do with the thyroid. There's a mass on the neck. So it's a clear critical sign. The doctor will talk to the patient, examine the patient, but they still do a blood test or even do like imaging on the thyroid gland. So it will never rely on a technology alone. It's what we call a multi-modality assessment. Our traditional assessment, interview, questionnaire are always there. And with a more accurate diagnosis, then we can achieve precision psychiatry. The next phase will be more personalized treatment. Now, I have been in the field of psychiatry for around 20 years. And 20 years ago, one of the hot topics is functional MRI. Very attractive. So we put the patient brain into MRI and see their function. So also a lot of research funding have put in the functional MRI in different countries all over the world. Now, if you talk to a functional MRI expert, you ask, hey, for the research funding, when you can actually use it in a clinical practice and patient can get a report, very often the functional MRI researchers say, well, this is still not for diagnostic purpose, it's still for research. Now, the cost of functional MRI is high. In Singapore, it's close to like 1,000 Singapore dollar at least. And even have a research grant, we can't scan so many people if the person had to scan multiple times. It will be translated to at least 5 or even 7,000 Hong Kong dollar. So as a result, even they do research, the sample size will be limited by the budget. And of course, high cost of having an MRI scanner. You can't have it in ordinary clinic, and you need to a special equipment to host the MRI scanner. Okay, don't worry. Okay, now then the other thing is our researcher, they like this concept called resting state MRI. Functional MRI is, okay, they just mainly rest there. They don't do a cognitive task and we see all this connection. But research also found that the test reliability of the resting state fMRI may not be that high. Now, but what we learned in the past 20 years, full functional MRI is this called BOL signal, the blood oxygenation level dependent signal, i.e. when someone do a cognitive task, the hemoglobin in the blood is going to bring the oxygen to the brain. And what we found that in very psychiatric illness, the oxyhemoglobin level is actually lower than healthy control. And it seems this marker is quite reliable and stable. Now, the question is, how do we actually bring it to the patients as a more cost-effective way? Now, this table compare fNIRS, fMRI, EEG, and PET scan. They all have its strength and weakness. Let's talk about fMRI and versus fNIRS. They actually based on the BOL signal. The range of possible tasks will be enormous for fNIRS is because the person is in sitting position. Later on, we will show you a video exactly what the patient goes through during the process. But the functional MRI, they rely in the MRI scanner. It can be noisy. And they can't move in the fMRI scanner. If people have claustrophobia, it will be an issue. People have a metal implants in the body, they cannot go into the MRI scanner. And fNIRS, we do have a young version for like primary school or secondary school student and adult. So you can do it on everyone, while maybe a young child may be a bit scared to lie in the MRI scanner. There's no noise with fNIRS. Nowadays, some of our devices are actually portable and they're available in Hong Kong. And of course, the good thing is actually you own the device. When you scan, sometimes you do experiment. Let me try this paradigm out. It's actually free of charge. While for functional MRI, we need to pay every time. Now, EEG, although many centers also have EEG, again, they also very good and very comprehensive and also portable. The only thing is nowadays, many people also, the patient themselves, they want to see the graph and they want to see a cut-off value and easy for the clinician to use in the practice. Now, PET scan, of course, is expensive, is challenging, and people also sometimes worry about side effect, etc. Now, the fNIRS has one limitation compared to functional MRI. It can't go deep in the brain. Some of you may have studied anatomy. In the brain, we have the skull. After the benefit is what we call the cortex. It's the surface of the brain. There are a lot of blood vessels on the cortex, and actually the fNIRS is measuring that. But you say, I want to measure some structure deep inside the brain, such as the hippocampus, which is important for memory, or amygdala, important for emotion. Unfortunately, we cannot go that deep. Then you still have to go back to functional MRI. So we all have our own strength and weakness. We have to choose and depend on what we want. So I'm going to talk about the technology of fNIRS, if this is the first time you hear about this. This is the principle. I'm not an engineer, so I also explain in a more simple way. So there is a source of the light and there's a receiver of the light. So they have to be in a distance of 3 centimeter or 30 nanometer, sorry, 30 millimeter. And then the infrared light will go from here, go to the cortex of the brain, and then pick up by the detector. So they will actually measure the oxyhemoglobin level of the brain when the person performs a cognitive task at a particular time point, at a particular location. You can say that, wow, then you will generate a lot of data. The answer is yes. Every moment, there's a lot of oxygen hemoglobin level at different parts of the brain when they're doing the cognitive task. Now, and the infrared light is between 650 and 1000 nanometer. And the fNIRS device, one place they must measure is the front part of the brain, because the frontal lobe is a very important part of our brain, differentiate human from primates, because we have executive functions. Now we have different devices. This is the larger device from Japan, which is stationary, but we also have portable device you can bring to different places. Our colleagues in Vietnam will bring to rural areas to perform their study or bring scan. So it offers the convenience. Now we partner with industry. First one is Hitachi Medical System, but now they transfer to Fujifilm. Then we have OBE Lab. Some of our colleagues in Hong Kong have heard about OBE Lab. It's a Korean company that produces the portable device. And we also, fNIRS is a company from Germany. Now, we are medical doctors. Regulation of devices is more sophisticated in Singapore than perhaps maybe in Hong Kong. And besides, hopefully, if we have FDA approval, it's very good. Like the Hitachi system have FDA approval. But if not, you may have the European approval and the local approval from the Health Science Authority in Singapore. Now, I, as a medical doctor or researcher, I cannot apply. The company have to apply. So especially when we use this on patients for clinical use, they must get the HSA approval. So for currently, there are 2 devices. The first 2 systems have the Health Science Authority approval in Singapore, and then we can use it on patients. This is a translational medicine framework from stage 1 to stage 5. I think it started many years ago in the 90s, when I was still maybe a medical student at that time. So our pioneer in Japan and Korea do a lot of preclinical study to see, does this infrared light go through the cortex and pick up the signal? Then later on, they will apply to human, and with their proof of concept study and sought the FDA approval or other authority approval. I think I start to join this at stage 3 is to translate to our patient in Singapore. We do case control study. So looking for a new method or cost-effective method for psychiatric diagnosis. Then we translate to other part of Asia, especially developing countries, because they say, well, we can't afford a very expensive machine and we have to bring it to rural areas. So that's, I think this is a picture using one of the fNIRS device in Vietnam, and they also help to recruit some patients that we have difficulty to access in Singapore. Now, I will go to my journey in the past 9 years. Most of my research were done with my PhD students, and we actually try to validate the fNIRS in different psychiatric disorder. As well, besides Singapore, we also conduct study in Vietnam. Now, based on our research, you will ask, what is the best cognitive task the patient should do during the scan? We found that one of the tests is the most sensitive and specific to differentiate a particular psychiatric disorder and healthy control is the verbal fluency test. There are 2 versions. The English version is they will do a warm-up. They will say A, B, C, D, E is a warm-up. Then the computer will say A. You have to think of words start with A. Apple, aeroplane, etc. And then suddenly will be another word like S. We have 3 different alphabet, and they have to think of different English word. Then you will ask, how about Chinese? Chinese or Cantonese, we don't use spelling. Then we could use category like animals, fruit, transportation tool. You generate as many as category as possible. Now, this is a study performed by my colleagues at HKU Psychiatry Department. Now, but they don't use fNIRS. They just mainly measure the response maybe by counting the correct response or looking at the number of switches. They found that people with schizophrenia compared to healthy control have significantly lower correct response, as I highlight in the rectangle, and they have a fewer number of clusters and also fewer number of switches. It seems that schizophrenia patient may have some frontal lobe impairment. They cannot actually think of other category. But the conclusion of this paper suggests that it's overall slower in the patient account for the group differences rather than any specific abnormality per se. Now, I have a different view with this conclusion. When we scan the brain, actually their function are different. Later on, I will show you the result when we perform on our Vietnamese patient with schizophrenia. Fabiha is in the slide here. She actually completed her PhD degree, and her PhD was focusing on fNIRS and different psychiatric illness. One of her first chapter is on major depressive disorder. So we get the 105 patient with a major depressive disorder and 100 and healthy control. And it's very important to actually generate what we call the integral value. What is integral value? I'm not a mathematician. I'm not good at this formula, but basically it means the area under the oxyhemoglobin level curve. As I mentioned, based on previous fMRI research, psychiatric patients have a lower oxyhemoglobin level. So that's why the area under the curve will be lower. And as a result, the integral value will be lower. Now, we are actually like our medical laboratory test, for example, anemia, we have a cutoff of hemoglobin level. So now we're using integral value as our cutoff. Above that, maybe actually a healthy range. Below that, the person may have a particular disorder. This is the result of a study. If you are first time seeing this result, very easy to understand. This is the frontal lobe. The green line represents the oxyhemoglobin level of healthy control. The red line is major depressive disorder. You can see it's actually the people with major depressive disorder is much lower than healthy control. This is the temporal lobe. Healthy control is also much higher than the major depressive disorder. Now, some of you may be in the psychology field or psychiatry field. You say, yeah, I heard about this verbal fluency test. I thought it's just frontal lobe, but how come temporal lobe is involved? Again, when we scan the brain, we have more information. When we do the task, let's say A, then of course the frontal lobe says, say, focus on this task. My first word is apple, but now I have no more word. Then the frontal lobe will say, okay, let's have think of other category. Okay, how about transportation tool? Now, the word, let's say aeroplane, will come from your memory and language area, which is in the temporal lobe. That's why usually in a healthy person, you can see the frontal lobe during the middle of the task when they generate words The oxyhemoglobin level is high in the healthy control because the frontal and temporal lobe are working together. Another thing is the task must be simple. If you have a task very difficult, the person is not doing the task. Now, and then we conduct this ROC receiver operation curve analysis and look at the optimal cutoff for the integral value in the frontal lobe and temporal lobe. And Fabiha found that for integral value 50, anything below 50 is major depressive disorder, above 50 is healthy control, have a sensitivity and specificity of 74%. For the temporal lobe, the integral value will be 80. This is the best, 76% sensitivity and 78% specificity. Now, you may ask why this is not 99%. Now, it's really challenging in our field because if we do, let's say, liver cancer, they all have a gold standard to compare with is the liver biopsy. So we suspect someone has liver cancer, put a needle, take out the liver cell, the pathology see in the microscope to confirm. In psychiatry, actually, we don't have a gold standard. Someone say our traditional standard, DSM, it may not be gold standard because it's reported by the patient. So as a result, our sensitivity and specificity may not be as high as other critical disciplines. But I have to emphasize that fNIRS is not alone. When people hear this result, they thought that, okay, you're going to scan the brain, that's it, right? You go diagnose depressive disorder by the scan. The answer is no. We still go through the clinical questionnaire, and fNIRS is one of the components. So if a patient fulfills the critical criteria and the fNIRS, the accuracy will increase. Now let's talk about some clinical application. This is a case, you know that in Singapore, men have to serve the compulsory military service, they call national service. So this is a 21-year-old man, seeing psychiatrist in TRC-17 because of some stressor in school and family, but he did not need many medication. He's very keen to serve army, but sometimes the army is a bit concerned because they worry, would this case have suicidal thought? Does he have depression? Is it safe to hold firearms? So we actually, besides talking to him, he doesn't have much clinical symptom. His Hamilton depression scale is 0, which means they have no depressive symptom at all. But if you say maybe he don't tell us all the symptoms, then we scan the brain, and as you can see, this is his result. The oxyhemoglobin level, in this case, the red line here, is very high. The integral value is 214. Remember, just now I said the cutoff for healthy and depression is only 50. He's at like few times higher than a normal cutoff. Is in a very good range. Temporal lobe is the same, 209. So in this case, we are more confident with clinical assessment, a questionnaire, and fNIRS to tell the military that, okay, this person probably do not have a major depressive disorder. He's medically fit to serve the army. The other question raised by our patient is, doctor, do I need to take the antidepressant for long term? I have some life event. I took the medicine for 6 months. Now I'm better. Again, we also can use this because if the patient, after taking the medication, the integral value is about our normal cutoff, again, if the depressive symptom is not too high, we may agree with them because ultimately, because my hospital is not offering compulsory treatment, it still depends on them they want to take or not. But if they say, I want one more thing to check, if the integral value is high, maybe we are more confident to suggest that, yes, okay, if you don't want to continue antidepressant and your depressive symptom is low, then you can stop the medications. Now, then Fabiha moved to another condition. It's called borderline personality disorder. Now, this condition may not be very often mentioned, but I think this condition does exist in Hong Kong. This condition usually in young female, they are cutting themselves with penknife, they have a lot of unstable emotion, they have fear abandonment, they feel empty inside themselves. When they are stressed, they sometimes have some transient hallucinations. Now, the challenge is, depression can occur in major depressive disorder, but it can occur in borderline personality disorder. Is there any way we separate these two conditions? So again, we recruit 31 patients with major depressive disorder, 31 with borderline personality disorder, and 105 with healthy control. And what my PhD student Fabia found that channel 36 in the right orbital frontal cortex, very important in regulating emotion and social behavior, because this area, it affects maybe in depression because the emotion is affected, and we found that there's an interesting pattern. The healthy control has the highest oxyhemoglobin level, then followed by the borderline personality disorder, and then lowest is the major depressive disorder. But it's only this channel 36 can differentiate. The other channel may not show different pattern for these three conditions. So again, then we may use it in clinical practice. We have this lady, she say, okay, some doctors say I'm borderline personality disorder, some doctors say I'm major depressive disorder. If you do a questionnaire, it's very hard to tell because on the borderline personality disorder questionnaire or the major depressive disorder questionnaire, the score can be equally high. But when we scan her brain and look at channel 36, then we look at the pattern. Her pattern is actually more congruent. This is the patient pattern, but more congruent, not exactly the same, but more congruent with the major depressive disorder than the borderline. So we tell her that, okay, probably you are predominant still major depressive disorder than borderline personality disorder. Of course, sometimes the borderline personality traits may improve when they get older. Now, this is a study conducted in Vietnam with portable device. Again, they're using the verbal fluency test. They actually tried the Stroop color test. Stroop color test, if you are in the psychology field, you know that this is a test of executive function. It's very confusing because you sometimes have to indicate whether the word and like red, is this really in red color? But this test is not as good as the verbal fluency test. So in Vietnam, I'm looking for a condition that I could not recruit in Singapore. It's called bipolar disorder. Now, you may say, what is bipolar disorder? It's a mood disorder. The difference between bipolar disorder and major depressive disorder is that depression, the mood is low. Bipolar, they have this manic phase. Suddenly they believe that they're the top of the world. You ask them, can you rate your mood 10 out of 10? They are very happy. They want to make a lot of new friends. They want to start their own business. They're a bit grandiose. The challenge is bipolar disorder may present the first time as depression. And if our doctors start a medication called antidepressant, it may trigger the manic episode. So there is this researchers, they want to find out, is there a way to differentiate bipolar and major depressive disorder? Now, first of all, when we compare bipolar disorder and healthy control, we found that the left orbitofrontal cortex is the area that can be the most sensitive and specific to differentiate from healthy control. In contrast, depression, the area that can the most differentiate in healthy control is the left dorsolateral prefrontal cortex. Now, the orbitofrontal cortex is important because it inhibits unwanted action, and people with bipolar, they can be a lot of unwanted action, maybe overspending, they may be inappropriate, etc. Then the big question is, how about unipolar depression versus bipolar disorder? Then the area that separates these two conditions is the bilateral ventrolateral prefrontal cortex and the right frontal polar prefrontal cortex. Yesterday, I visited the anatomy lab here. This is also an application of functional neuroanatomy, and the frontal polar cortex is important in planning, problem solving. What we can see clinically, bipolar may plan more or they may do more things, but of course, their pain may be very impulsive, while depressed patient may lose the motivation. So this area can actually separate the two conditions based on our patient in Vietnam. Now, the other condition I want to study is schizophrenia. Schizophrenia is a condition that affects 1 in 100 person. They lose touch with the reality. So when they're unwell, they hear voices, we call hallucination talking to them, or they have a false belief within someone to harm them, we call delusion. So from the previous fMRI research, they already found that you see a lot of blue color here in the schizophrenia brain compared to healthy control when they do the verbal fluency test. It's because the schizophrenia do not send much oxyhemoglobin level to the brain. That's why the oxyhemoglobin level is very low, and in the two-dimensional color map, it will appear as blue instead of orange or red. Again, the right orbitofrontal cortex is the area that is the most sensitive and specific to differentiate schizophrenia patient and healthy control in Vietnam. The sensitivity and specificity, again, is around 70 or 80%. Now, I also conducted this study in China. A very interesting study called to use the infrared brain scan to study high express emotion. Now, you can't do it in fMRI because fMRI, if you have tried before, it's very noisy. But high express emotion, they have to hear audio recordings. Now, what is high express emotion? In particular for schizophrenia, but I think it's for everyone, people's mental health will not be good if you stay with a family member who is very hostile, very over-involved in your personal affair, or offer very critical negative remarks. If this kind of environment is more than 35 hours per week, this increases the risk of relapse in people with schizophrenia. So in China, our collaborator conducted this study. No one had done this before. We know about this concept of expressive emotion for many years, but no one has actually scanned it under the brain. We don't know what's going on, but let's see the result. So we asked the person to rate on the questionnaire. There's a different type of comments. Some are what we call low expressive emotion, very supportive. Some are very critical and negative. You can find that the subjective rating, the patient actually, very interesting. The gray bar represents schizophrenia. The transparent one is actually the healthy control. If low EE are very supportive comment, it triggers more reaction in the schizophrenia patient. In contrast, in the high EE, the healthy control will rate this comment maybe more triggering than the healthy control. So, the healthy control rate more triggering than the schizophrenia patient. Now, then when we scan the brain, this is an interesting finding. We found that people with schizophrenia exhibit a smaller hemodynamic activation in their language area across all the whether low E or high E situation. And people with schizophrenia show a weak and insignificant hemodynamic deactivation. Now, we are not sure why is they deactivate during this high expressive emotion. Could it be they have a protective mechanism to protect themselves, not to be too reactive to high expressed emotion comments? This is the first time people scan the brain when they're exposed to this kind of comment. I think further research needs to be done to understand the brain of our patients. Now, one thing I want to do, but I don't have the chance, is mild cognitive impairment and dementia. This is a finding from Korea, which they're using one of the device, a portable device. But one of the problem is even they conducted research, but they have not done the integral value. I cannot use the result, except I can see in the two-dimensional color map, people with amnestic MCI compared to the non-amnestic MCI is more blue compared to orange. It means that amnestic means that mild cognitive impairment predominantly with memory loss, they have less oxyhemoglobin level to the brain when they do a cognitive task compared to people with MCI, but basically they have difficulty in making the right decision, judgment, or planning. But I really hope to do this study maybe in Hong Kong or Tung Wah College, is to find out what is the integral value cut off between elderly with normal cognition, mild cognitive impairment, or dementia. And then we can use it in clinical practice. Okay, now let's talk about some intervention. I have a visiting scholar, Ji Sung from Huaibei, China. He came to NUS High Health Tech before the pandemic. He is a hypnotherapist, but unfortunately our ethics don't allow him to do hypnotherapy research. So he said, okay, I want to do a relaxation exercise research. And he wants to see healthy people, let's say they do a relaxation exercise with guidance, and then they do mathematical tasks before and after the relaxation exercise versus a control intervention. The person is just sit there not doing much. What he found is that those who actually these are healthy people, exposed to relaxation exercise, when they do the maths, after relaxation exercise, they can send more oxyhemoglobin level to the brain compared to people who are in the control interventions. So maybe have a clear thinking. Now, because the fNIRS is portable, we work with the National Park Board in Singapore, bring our device to the park, scan people in different environments. This is our previous medical students, and I think it's very relevant for here is doing a procedure. We actually scan the brain. One group of students were well trained during laparoscopy. One group actually struggled, and we found that those who actually well trained, they're more relaxed. In fact, when they do the procedure, we don't see so much oxyhemoglobin level because they're actually very confident. It's like a habit. But those who are struggling, who are not well trained, they actually send a lot of oxyhemoglobin level to the brain. So this is an interesting marker to see whether they will train adequately for a procedure. We also do research on medical education. I think very relevant for Tung Wah College on our like nursing student or allied health for exam. There are 4 types of exam questions, written exam. I'm sure you will use some of these. True, false. Here, the first one is TF, is true, false. So I give a statement, yes or no, true or false. Then multiple choice, choose the best answer out of 5 options. Short answer question, and clinical reasoning. There's a clinical scenario you have to answer based on the interpretation of the clinical scenario. So we scan the medical student brain when they're doing these 4 different types of exam questions. As you can see, the frontal lobe and the temporal lobe, one is for executive function, one is for memory. they send more oxyhemoglobin level for the clinical reasoning question. So critical reasoning question may require more mental process compared to true-false statement. Now, I just talked about, it seems that if there's more activation is good, the activation seems to be like associated with disease or something like that. Is there any scenario that the activation may be a good thing? So this is a study in fMRI, but not fNIRS. They found that it's very interesting. If the person, let's say, exposed to the future spouse, let's say maybe see the picture and they scan the brain, if they are more deactivated, it's actually predict a longer or better marital relationship. This is very interesting. It's not they are more activated. They may be more deactivated at the first look, then they actually the relationship lasts longer. Now, the other thing is we bring the fNIRS scans to the National Park Board, and then the National Park will bring to 3 different areas. TG stands for the therapeutic garden. You know, Singapore, they build a lot of beautiful garden. This is called therapeutic garden. RG is the residential area, like our public housing. BD is a very busy business district. So if you ask them to rate the questionnaire, whether it's patient before and after or healthy control before and after, they will find that, well, this is very stressful. They gave a high score in the questionnaire on their mood. It's very stressful, negative emotion. Then when we actually scan the brain, we found that interestingly, in the therapeutic garden, they cause more deactivation than the business district. This is another example showing that although in our patients, sometimes we expect to see like more activation in healthy people, but in this case, the therapeutic garden is more relaxed. They actually have a low oxyhemoglobin level. This is the finding. I talk about the laparoscopy. These are the people who are actually well trained. They do the same procedure. They actually no need to activate the brain so much compared to the untrained group. During the COVID pandemic, we also do an fNIRS study on people who recover from COVID. We were interested about how their brain function when they exposure to smell. The olfactory bulb is in the front part of the brain. Although I cannot measure that area, again, we measure the frontal and temporal lobe. But you can see that the oxyhemoglobin level healthy control in this case, when they are doing a smelling task, is higher than the COVID patient. The heavy control and the blue line, the COVID patient are in the green line. So same for the temporal loop. Okay, I have shared with you some of my research, my journey with my PhD students. Then of course, another hot topic is machine learning or AI. So in psychiatry, if you want to apply AI, then the question is, the machine say, can you give me digital data? So an fNIRS is one of the digital data. So Zifei is a student from China. He obtained his PhD. Now he returned to our NUS campus in China to continue his work. So his whole PhD thesis, his background is a computer scientist. So he uses knowledge in machine learning to actually analyze the fNIRS data. I'm sure in the audience, some of you are expert of machine learning. I think you know this method better than me. So the first one is the support vector machine, which is they will just say, okay, we actually have 2 groups, and then they will go for further analysis called discriminate analysis. They will say, okay, maybe based on 1 variable, we can separate them. How about multiple variable? Lastly, the k-nearest neighbor is actually, they will learn. They have a training set, then they have a set that is a test set. They get use what they learn in the training set and they separate into the test set. So in his study, using machine learning based on fNIRS signal, he said the correct prediction rate for major depressive disorder was 78% with sensitivity and 75% specificity, and this is actually very in line with our previous research. I think the correct prediction rate is about 78%, sensitivity 75%, specificity is 81%. So the correct prediction rate is around between 70 to 80%, very in line with our other conditions or other methods. Cyrus, Dr. Cyrus, who is an assistant professor in my department, he also did his PhD. His PhD actually looking at fNIRS and other blood biomarkers. And if The area under curve for just clinical diagnosis is 0.82 with fNIRS and some of the amino acid biomarker. He actually, with this multi-modality assessment, he raised the area under curve to 0.92. So this is a demonstration. fNIRS can be part of the multi-modal assessment. This were my PhD students. They work on different projects. Many of them, they graduate with publications. Now, we talk about a lot of research. How about clinical application of fNIRS? And also one more technology is what we call oculometricity or automated eye tracker device. This is a request from our patient via email. The patient say, okay, I received some therapy for anxiety, depression, ADHD over a year. The therapy is not going to anywhere. I've been thinking of an official diagnosis. 2 psychiatrists saw me, but not conclusive of my diagnosis. I want to see you, and then you give me a deeper understanding of my condition. This is an email written by patients, and this is a clinical need. And the eye health tech, where I work, have 4 missions. Identify critical clinical need. We actually have innovation that would disrupt the health solution or maybe offer new technology. We incubate to bring health technology from bench to bedside to clinic and impact to patient, doctor, and the society. One of the study I published in last year is on the adults with ADHD, attention deficit and hyperactivity disorder. You may ask, should ADHD be just a childhood disease? In Asia, Hong Kong, and Singapore, we have many people, many adults say, I have ADHD. I was not diagnosed when I was young. My parents did not bring me to see a doctor. I'm struggling with my inattention. Inattention is something like pain. Only the patient can feel it. We cannot feel the inattention. Some people also like this. They are okay on their own. When they get married, the spouse cannot tolerate the inattention. So, and the other thing is ADHD, the medication is a control medication. So some of my colleagues are very cautious. They don't want to say, okay, you read all the DSM-5 criteria, you come, then you will fulfill all criteria. But I don't believe it because you don't have a childhood record. Then we always have this debate between the patient and the psychiatrist. So we use the fNIRS. Again, we recruited 75 healthy control, 75 patients who have never tried ADHD medicine, and 45 ADHD who are on medication. As you can see in the frontal and temporal lobe, we have this pattern. The healthy control will have the high oxyhemoglobin level when they do the verbal fluency test, followed by those who are on medication. Those who are unmedicated have a lower oxyhemoglobin level. Same for the temporal lobe, but the more drastic difference is the frontal lobe. But it makes sense because frontal lobe is very important for attention. Although forgetfulness, i.e. memory is not so good, is also a diagnostic criteria for ADHD. Then we look at the cutoff. The frontal lobe is below 69.5 and temporal is 96.65. The sensitivity and specificity is higher in the frontal lobe than the temporal lobe. I think it makes sense because frontal lobe is more relevant for attention. Then we also have the new device called the automated eye tracker. We have analyzed our data. We just submit our papers. Hopefully in the future we can share with you the result, but this will combine with the fNIRS and other device. This is invention by the French, and there are 3 tasks. The gap task is actually the easiest. What is happening in the gap task is, I would say it's a warm-up exercise. Is the person initially start with this fixated turn point. Then if the cursor move to the left, the eye just move to the left, and they measure the speed. And when do they start to move? Because many ADHD is actually they have a lot of idea, they're distracted, and then they don't move, and then they take longer time to start to move. Let me see whether it works for the demonstration. I think it's not really working. Does not matter. I will explain to you. Now, this one, the second task is the intermediate level, is called overlap task. Again, there's a fixation point, but you see the fixation point, different from the previous task, the fixation point still there, does not disappear. So for ADHD, they cannot focus. They say, should I look at the green or the red? So then they will be, again, slow to start, take longer time to start. Now you see, this is one example. You just now the 2 dots are together, and then they say, do I look at the white, this white one or the green one? The ADHD sometimes they cannot focus. Then the last one is the anti-saccade task. This is the most sensitive and specific task. Basically, what they were told is, if the green dot move to the left, your eye moves to the right. Now, of course, if you do one time, it's easy, but if you do it consecutive, even healthy people will make mistake, and they cannot move to the opposite direction. It can't at one mistake. Now, yeah, I have to move to the opposite direction, but this is only one time, but you do multiple times, the ADHD will get confused, and one of the very sensitive marker is the number of errors they make. Now, National University of Singapore, they have high requirement for academic going for promotion and tenure. For clinical faculty, those who are originally from as a doctor, they have a criteria is, okay, you publish paper, people cite your paper, but one more thing we want to see is, can you change clinical practice? It's not easy because in our field, it's very often directed by United States, Europe, etc. How about in Asia? We change our clinical practice. So we have patients who bring our report, show to the psychiatrists in America. They say, oh, I've never seen this before. So this is a challenge imposed on us. It's no longer just publication, but change the clinical practice and people talk about it. This is the procedure of our ADHD assessment. Actually, we can assess for other conditions. I will explain to you later on why we are focused on ADHD, because our main source of client is from adult with ADHD. First, take a consent form. It's a medical procedure. Now, this is nothing about research. We have to look at something called medical ethics. We can't do things like inferior than our colleagues. So many people are misunderstanding. You just scan the person's brain and diagnose ADHD. My answer is no. They have to fulfill DSM-5 criteria. And I actually, DSM-5 criteria, and they have to also have the certain cutoff. They have to, let's say, T-score about 70 in quite a number of domains in the corner adult ADHD scale. In fact, many of our colleagues may not have time to do the corner adult ADHD scale. This is the basic requirement. So we can't diagnose a person with ADHD if these two parts are not fulfilled. Then there are 3 objective tests: fNIRS, the automated eye tracker, and we incorporate one of the more traditional tests is called the continuous performance test on a computer, again from the corner organization. So this test is, they will see a series of alphabet. Then if X appear, they don't do anything. The other, they have to press space bar. But sometimes they also make it a bit delay. So for example, alphabet appear, then nothing appear, the ADHD people will start to daydream and then they don't react. So they pick up the reaction time and mistakes. So our criteria at this moment, it may change with our research result in the future, but at this moment, we require them to fulfill at least one of these objective tests. They must be in ADHD range. You ask, what will happen if they are all normal, but the person complaining of all the DSM-5 ADHD symptom? We will say it's symptom only, but not disorder. And our treatment actually is different. We will not issue the control medication in that case. Now, this is a classical case of ADHD. Mr. N, he actually complained of the following symptom: cannot focus on work, which affect his relationship and colleagues, and he find himself very disorganized. He often loses his belongings, and then he actually does not like the tasks that require attention. He can be easily distracted. He cannot follow instructions. The hyperactivity symptoms, again, he have a lot. Like he cannot wait in a queue, restless. He's an impulsive person, and he can interfere with other people's speech, and he has difficulty in sitting still in his class, and very talkative. Many of the ADHD adults, they have difficulty in driving. They take a long time to pass the driving test. Is because they cannot focus on the road. So based on the symptom, he fulfilled both the DSM-5 in attention and hyperactivity. Now, then look at the corner score. His overall score is high, is 227. This is our own center classification. Such a high score we consider to be a severe ADHD symptoms. And he's consistent also. Some of the people have a high inconsistency score. They may exaggerate the symptoms. Then the T-score about 70 means that compared to men in the age group, all these symptoms are actually at the top few percent. So the coroner also support he has ADHD, and he has some mild depressive symptoms. This is the infrared fNIRS scan. This is a healthy control. We always put a healthy control for patient to understand, and this is the patient. You can see the oxyhemoglobin level is low, and by the middle of the task, he dropped to negative. And he's below our normal cutoff. He got 61.3, and this one, the temporal also below our normal cutoff. So he fulfilled the fNIRS criteria. Eye tracker, at this moment, this parameter we borrow from the French, but we have established our local cutoff. But let's look at this one based on the manufacturer data. Color in red means that all his parameters are in ADHD range. The anticipation is he have a lot of like premature eye movement before the task supposed to start. Maybe he's thinking about something else. He's slower. The last task, he actually all in ADHD range. He took longer time to start. He had a lot of premature eye movement. He makes 62 mistakes. I.e., when he cannot look in the opposite direction, it's one mistake. Average ADHD, 25 mistakes. Heavy people may make less than 10 mistakes, but he's actually quite high, 62 mistakes. And the computer test, they also found that this is a come up with a conclusion. Company is performing with a large database because he has a high rate of missed target, slow response time. They say he have a high likelihood of having ADHD. So this is the outcome of this person. We will generate a report in 1.5 hours. So in his case, very clear cut because he fulfilled all clinical and all objective tests. So if someone say, no, I don't agree, we let the patient to decide. Maybe we have colleagues have a different view, but if he doesn't have ADHD, means all these test results are not correct. But it's very hard to say they are not correct because they're independent of each other. This is the report we will call very highly suggestive because we may still have some clinicians have a different view. We say it's up to the patient to decide. Patient without ADHD. Now, this is a person who only got a very low score on the corners and then have a high integral value. The eye checker 0 out of 7 criteria. CPT also say cannot detect ADHD. And this is the brain scan of this healthy person. You can see it's actually very high. And in this case, is a person we say is a normal finding. There's no ADHD. This is the people will call some symptoms, but not disorder. So this patient is very tricky because you can't, they have actually still more than 6 out of 9 symptoms in the inattention. Sorry, he does not fulfill. He has 4 symptoms for inattention and then 2 for hyperactivity. So he actually doesn't fulfill the DSM criteria, but he has some symptoms such as disorganization, easily distracted or easily forgetful. Then for the corner score is 146 is mild. And some of the T-score just hit the 70. But you look at the fNIRS scan, he's actually as good as a healthy person. Eye tracker, our current criteria must be at least 3 out of 7. He got 2 out of 7 is still considered normal range. The computer test say, the CPT says actually did not find anything suggestive of ADHD. So this one we will say he has some symptom only, but do not fulfill the criteria for ADHD. This is based on a very preliminary audit we did last year. So out of all the ADHD patients, majority, 54% fulfill 2 objective tests. 24 fulfill 1 test, and then fulfill 3 tests is around 21.6%. And as I say, the treatment is different. If they actually have symptoms, we will not prescribe control medicine. We will prescribe non-stimulants such as bupropion, clonidine, or omega-3 supplement or psychotherapy. Those who actually have fulfill our criteria, they are eligible for stimulants. So this is ADHD, and the prevalence is common. It's a 2.58% with ADHD, and symptoms is 6.76%, and it has a lot of challenges. And in NUS, we use our technology to overcome this challenge and give an objective report in a reasonable time frame, 1.5 hours. Now, I think I go to the last part of my talk. So you may say, maybe I heard a lot of research findings, but how about business? So I want to talk about my personal journey at NUS for commercialization. Now we have to move something from our comfort zone or where we are very experienced with, like H-index citation. Business is different. It's not about H-index or citation. It's about your image, mutual trust, how people feel about your standard, etc. Now, many of the engineer inventors, they actually have an idea in the laboratory, but they always think this is a great idea. I am a bit critical because I'm always appointed as a consultant to evaluate this idea in mental health because the investor say, hey, this company approached me, do you think there's a market? But very often they just think inside the laboratory. They never think from the end user. In fact, one of my questions to all the startups is, do you have an end user? Or can you show us who are your end user? Of course, I want to share first a successful story from Hong Kong. Professor Dennis Low from CUHK, you may have heard about him. He actually very specialized in prenatal diagnosis. He also used his technology to detect cancer because he found that the cancer actually send the fragmented abnormal DNA in the blood, and then you can actually detect cancer with the blood, and then he's a joint venture with a company in the US stock market. And you can see, the balance sheet he had last year. This is a successful story. There's a market and there's a revenue. Now, many engineers work on device during the pandemic, but of course, even they have a wonderful device, this example with detecting saliva, but at the end, people don't use this device because they will do this rapid antigen test at home. So again, although we have a brilliant idea, but this is called being outcompeted with later more convenient, cheaper alternatives. Now, startup rate have very high failure rate. 1 in 5 business fail in the first year, and then by 4-year mark, 55% fail, 20-year, 80% fail. They found that healthcare startup have higher survival rate than construction industry, around 56.9%. They actually survive after 5 years, and many startup fail. It's global phenomenon. I just attend our I Have Tech retreat. We have an entrepreneur just tell us how many startups not successful. And we also hear this term called unicorn. People thought unicorn means it's the only player in the market must be successful, but unicorn can have a high failure rate. Some of you, if you're very familiar with our local stock, there's a unicorn. I was also the investor, but its price dropped significantly. So I cut loss when it dropped by $2. Then it's dropped to cents at the end. So sometimes we have to be very careful. It's about, unicorn may not be guaranteed success. And we also have to look at it in a critical way, whether it's really have a market. Now, top reason why startup fail. Of course, they run out of cash because many of the startups, they may not have an end user. So they depend on investor or grant. If there's no grant, no investor, they run out of cash. The second reason, as I mentioned, no market needed. They have a brilliant idea in this thought that many people use in the lab, but not in the reality. Got outcompeted, a false business model. The other thing I always highlight to people who don't do medical translation is regulatory and legal challenges. They don't think about the doctor because when the doctor uses a device, they may be subject to legal challenges. Patient may complain. So they need to know that actually the doctor have this concern. Pricing, it cannot be super expensive. Then the other thing is, of course, more team-based that affect the outcome of startup. Now, based on my research, you will say, okay, these are the paper of fNIRS I published. Can I predict the success of your clinical translation based on your impact factor? But you'll be surprised. The most successful is the ADHD, which has the lowest impact factor. It's only 3. My other like 10, 11, unfortunately, the patient with depression not interested. Schizophrenia also not so interested. I don't want to scan. People say, I look so depressed already. Why you need to scan me? So it's very interesting. It's not based on your impact factor and all this. It's based on other factors. And also, of course, we also have to make sure our device have FDA approval before we apply, HSA approval. Of course, someone studying business, we know this thing called supply and demand. So in the ADHD, there's a demand. I think I have ADHD, but I was not diagnosed. People don't believe in me, and the medicine is a controlled drug. I need to be further confirmed. There's a demand. So we have the supply. As I mentioned, this is a condition is common. So we don't look for very rare condition. You only find 1 in 100,000. These are the common challenges faced by adults with ADHD. In Singapore, they say that they very long waiting time in the public health system. And some doctors say it's a waste of resources to get you diagnosed. The second patient say, well, there is only questionnaire and nothing given to us. The third patient say that, oh, I don't have a primary school report card. This is a requirement for some of the traditional psychiatrists, but honestly, I don't have my primary school report card. I can't impose on my patient. I probably carry somewhere. So, but many patients also don't have a primary school report card. Now, marketing strategy. This is something maybe for academics we are not used to. Now, I'm going to show you a TikTok video by a YouTuber. She come for an assessment and she make a YouTube and put under her channel. After YouTube, we get a lot of referral. Actually, currently our waiting time is 1 year because of this. So TikTok is more powerful than traditional media. And you also can see the process. These are type confirm your ADHD. ADHD symptoms based on the frequency. Do you feel nervous? You feel happy very fast, very shaky, go toilet very often?
Okay, I try to look at the back. The important thing is during the whole scan duration, try not to move your head or any part of it.
Eyes open. It's to not furrow your brow.
So for this task, focus towards the center. There will be a dot appearing either on the left or on the right of the screen. To do is look towards it, and once the dot disappears, look back to the center of the screen as quickly as you can. So for every letter you see, just press the space bar. But if you see X, you don't press it. Try to keep your full focus for these 10 minutes. Okay, so let's start.
Okay, so 19 minutes later, the result was out and we gave her the report. Now, we also appear in local newspaper, Straits Times, one of the English newspaper in Singapore, but of course, the marketing strategy is actually more powerful with those social media with videos. Okay, this is an inquiry from international patient from Vietnam. This Vietnamese read the Straits Times article. He said he suspected ADHD, but he could not find such an allergy in Vietnam. So he came to Singapore, took the plane and do the assessment. So the main source of income was startup. We always hear about license. Recently in our retreat, one of the entrepreneurs also warned us is that if your company is based on license, if the product cannot sell, then people will not pay your license. People will not pay a license because they have financial problem. They have to pay the staff first. Then it will go upstream. Is actually we don't have license, then the original startup also cannot sustain. Now, the other thing is, what are the factors that impact patient willingness to pay? Income. ADHD, actually, people have higher income than other psychiatric conditions. Age. Although people say ADHD parents with ADHD shouldn't like to spend more money than the adult with ADHD. But what we observe is actually the adult ADHD willing to spend more on themselves because our society changed because of low fertility rate. So people will spend more resources on themselves nowadays. And gender, we also have quite a number of female patients coming in for assessment. And based on the condition, if you look at common cold, for example, people would not spend a lot of money. When you talk about $40, people already significant proportion drop. Of course, you talk about like myocardial infarction, people will spend more money. It depends on condition also. So ADHD for patients, they may have a price. They may not want to spend very high, but not too low. This is the income at iHealth Tech. NUS, our university will take 20% of the income. And then we have other for like manpower and also for academic use. Currently, our price, this is the last year price, we have increased the price this year. But of course, compared to another center, we benchmark is a Chinese University Medical Center for Dementia Screen. They are around 4,000 Hong Kong dollar. Currently, we are still 2,005. So we still maybe have room to increase the assessment fee. And we are planning for another center in Singapore. So we will have two separate centers. The NUS one in the future, maybe mainly for referral from our hospital and from the university. We will have another one in the east side of Singapore near the airport. This is from an investor on our assessment. They will say that this is the understanding our team is only in the world utilize this unique combination of assessment for ADHD diagnosis. Now, this is my personal experience, not based on research funding. Some of the indicators for success or failure can be quite paradoxical. For example, when we disrupt the market, our competitor may be the one that's affected the most. You will have complaint or attack from a competitor. We also may have difficulty to get research funding because very successful translation, they will say that you already generate enough revenue to support yourself. So you don't need further research funding. And this is also a very important concept for sustainability. You generate income to support your staff and your future development. Positive response mainly from your client, expert or 40 sometimes may keep quiet. Now, and some indicator of failure is when I assess startup, I will say, why you have no other source of income besides investor? And they are seeking new investor without expanding or just maintaining the current operation. There are the startups say that I will give out license free of charge. It also indicated no one buy the license. If a field you already have a lot of startup, but there's no actual critical application for years, is also not a good sign. I actually have this golden time frame is 10 years. If someone starts from the beginning to 10 years, it still cannot translate. Maybe this product may not have a market. And we're also very cautious for people who only sell a science fiction idea. Oh, this will work in the future. But we say, when is the future? Or always remain as a startup. So this is my final conclusion. I know it's a long lecture. Psychiatry is the only specialty don't have an objective diagnostic method. And I have illustrated the functional near infrared spectroscopy is a cost-effective functional imaging modality. And we actually differentiate different psychiatric disorder from healthy control. But the adult ADHD seems to be the only one have a commercialization potential. And in NUS, we are talking about this is a multi-modality assessment, clinical, fNIRS, eye checker, etc. Startup or sometimes even unicorn may have a high failure rate. The success of clinical translation depends on customer preference, supply and demand, marketing strategy, and very important, whether medical or legally it will be accepted. And very important question, for successful commercialization, where are the end user and are they willing to pay? And 10 years is a good time frame to actually measure a success of a startup idea. Thank you very much.